In a gentle way, you can shake the world. Mahatma Gandhi. Welcome to the Guyana Dialogue. I'm your hostess, Shamiza Ali, and it is truly a pleasure to be here with you this evening. Good evening to everyone joining us on Facebook and YouTube. Tonight's topic is an update on the various health projects in Guyana, including the work of Mount Sinai and Northwell Hospitals. The Guyana Dialogue is being sponsored by a coordinating council of Guyanese based in the US, UK, Canada, Guyana, and the Caribbean. Funding support is by well known philanthropist Dave Narayan from Dave West Indian Imports. Please welcome my moderator for tonight, Dr. Tara Singh. Our panelist tonight is Professor Muniram Budu, and we are privileged to have a new panelist, Professor Narayan Prasad. Here is a little detail about him. Mr. Prasad was born in Plantation, Bath, where he attended primary school. He studied at Inter-American University in Puerto Rico, Ohio University, Kent State University, and Florida State University. He holds a PhD in sociology and social psychology. He taught at UG, University of the Virgin Islands, Florida State University, and Florida A&M University. He also served as a policy analyst and a legislative analyst for the state of Florida. His published articles are in the areas of development, family, juvenile justice, and policy analysis. He is a professor emeritus and enjoys retirement with his wife, sons, and grandchildren. Now, please welcome our guest for tonight. He is the advisor to the Ministry of Health, Dr. Leslie Ramsamny. Good evening, everyone, and welcome to the Guyana Dialogue.
Good evening.
Dr. Tara, please go ahead.
Good evening. Thank you very much. Thank you, Shamiza. Welcome to our viewers and welcome to our panelists, Professor Muniram Budu, Professor Narayan Prasad, our host Shamiza Ali, and then our guest, our special guest tonight, Dr. Leslie Ramsamny, who was one time, I don't know if you still hold the status of professor, but you were a professor at Upstate University, some university upstate. Am I right there?
I was a professor.
Dr. Ramsamny.
Yes, I was a professor of medicine at Stony Brook, at the State University at Stony Brook, and also Menschel Fellow at Harvard University.
Good. Thank you, Doc. Before we start, would you like to make a little commentary on the passing of Dr. Roger Luncheon?
Yes, Roger and I worked for a long time. I feel blessed that I got an opportunity to work with a man like Dr. Roger Luncheon. I've been blessed that I've worked with so many persons that are larger than life. Dr. Terry Jagan, Mrs. Janet Jagan, Ashton Chase. Presently, Dr. Bar Jagdeo and Dr. Irfan Ali. For a long time, Roger and I worked together on the political hustlings in the cabinet. Very few people remember that the new constitution, one that we amended and introduced in 2000, with more than 200 amendments to the Burnham 1980 Constitution, that Roger Luncheon and myself represented the government and the oversight committee to draft the language that we presently see in the Constitution. Roger Luncheon was a man full of humility, but a man whose intellect and commitment to public service knew no bound. Dr. Luncheon was an icon indeed. And as much as he was a powerful person. I think people need to know that under every single president um, that served the PPP governments, from Dr. Cherry Jagan, Mr. Sam Hines, Mrs. Janet Jagan, uh, Donald Ramtar, Bara Jagdale. Um, Roger Luncheon was the second most powerful person in the country. And as much as our presidents and our cabinet relied on his intellect, his competence, his ability to translate very complicated, complex matters into straightforward presentations, I think the one thing that the presidents and the ministers shared in common was that we totally, absolutely, unconditionally trusted Roger Luncheon. I think it was the most important um, character feature of Dr. Luncheon. For those who knew him from the younger days when he was a young doctor, remember that he was Guyana's first practicing nephrologist in country. There might have been others who practiced abroad, but Roger Luncheon was the first practicing nephrologist and taught many of the senior doctors in our country today who graduated from the local medical school. Um, and in those days, people remember him. He didn't have a car, he rode a bicycle. Those big, I think it's called a Humber bicycle, those big ones, um, to the hospital. And as one person who saw him in 1989, for example, Roger would come into the compound and drop the bicycle anywhere in the hospital. Nobody ever dared touch Roger's bike. Um, but Guyana's modern law on regulating medicine and regulating the practice of medicine, regulating the practitioners, the doctors, um, Dr. Roger Luncheon led the way. He took on the then Minister of Health, Mr. Hamid Green. He took on the Hoyt government and ensured that we had a medical council that the government could not control, that functioned independently. So it doesn't matter which facet of life in Guyana Roger Luncheon touched it, because I was closely linked to him and his struggles in later years with his health. I feel personal pain. Um, but I think that the personal pains that many of us, people like Bar Jagdeo and Irfan Ali and all of us would feel, um, is just a small um, loss compared to the loss that Guyana has suffered. Um, People will come and they will walk his journey, but he is irreplaceable, just like Chad Jagan was irreplaceable. Um, and just like Bar Jagdale and Irfan Ali would be, I think Roger Luncheon fits that mold that he is irreplaceable. However, let me end on this, that Roger mentored many. And whilst we cannot fill his shoes, we could carry on the work he started. And that's what great men are made of, great men and women, in that even though we feel the loss, the void can be filled because they leave others to carry on. I am proud of the work that we did together. I am blessed that Roger was my friend and gave us the opportunity to work with him. Guyana is better off because of men like Roger Luncheon. And I think I wanted to end on that point, but I think I should tell the story. In 1989, when many of you were paying attention to what was going on in Ghana, and we were beginning to see the light. Jimmy Carter had come to Guyana. We had begun to feel confident that we would be able to have a free and fair election. There were many who said that Chetty Jagan should not be the candidate, that we should have a coalition, and that coalition should be led um, by someone else than Dr. Jagan. And some people believed, and some people pushed the narrative that it must be an Afro Guyanese. And Cherry Jagan, as he is wont to do, and create compromise for the larger good, agreed that he would stand down. And the PPP nominated for that position as the head of the coalition Dr. Roger Luncheon. The WPA and others rejected that nomination because they said he is black, but he was too red for them, meaning that Chedi Jagan's party had put up a communist. Um, but there was no more pragmatic, practical person. Roger Luncheon, like his hero, Dr. Chedi Jagan, was not just an ideologue. He was interested in what was good for Guyana. Today we are a better country because Roger lived and worked among us. God rest his soul, and may his soul rest in peace.
Thank you very much, Doc. We at Guyana Dialogue also express our condolence to his bereaved families, friends, etc. Now to our topic. The first question I want to pose to you before I bring on the panelists is a question a lot of people have been asking us with the proliferation of the construction of hospitals throughout the regional hospitals throughout the country. I don't know if there's 8 or 10 or what, but they're asking the obvious question: would you have enough medical staff to man these new medical facilities?
The human resource for health today is better than it was 20 years ago. That doesn't mean we have all that we need. We are short of nurses. We need more specialists. Um, Allied health is a major um, constraint in our country. But in all of the areas, we are better off. We have more people. We have better trained people today than we were 20 years ago. We have far more than when I was Minister of Health. When I became Minister of Health, we had 120 doctors um, in the country total, both public and private. Today we have over 1,000 doctors. Um, at that time, we had a handful uh, of specialist doctors, Guyanese specialist doctors. Most of our specialists at that time were from Cuba, from India, from other countries. Today, we have almost 300 specialist doctors in our country. We have 3 times more specialist doctors today than we had total number of doctors in the country when I first became Minister of Health. However, in spite or despite the fact that we are more equipped today in terms of human resource for the health sector, it is still not what we will need to elevate the health system in our country, and also to provide the services that all these new hospitals and new technology will need. And so we are preparing for that. So let's take nurses, which is a need in all countries, including the United States of America. I suspect that for the nurses that we have trained in the last 20 years, more than half of them are working at Northwell and Mount Sinai and hospitals in the US. But we had a capacity when I was Minister of Health for, well, when I became Minister of Health, a capacity to train 100 nurses. By the time I left, we were training about 250 nurses per year. Um, as of this year, this incoming class, this incoming class, which started about 2 weeks ago, we have taken in 1,250 young people to study nursing. And by next year, we will take between 1,500 to 2,000 young people into nursing. We that if all of them stay will be more than we need. However, because at the moment we are about 2,800 nurses short of what we need. Um, so, incidentally, we also have specialized training. When I became Minister of Health, we only had one area of specialist training, which was midwifery. Today we have, by the time I left, we had introduced anesthetic nurse, psychiatric nurse, pediatric nurse. But since then, we have added more. We have trauma nurse, we have NICU nurses, so a number of specialized area in nursing. Um,
Just before we proceed, a clarification. What period were you Minister of Health?
2000 to 2012. Um, so the longest serving Minister of Health at that time, and still um, around the world. The only other person that came close was Julio Frank, who's now the president of um, of the University of Miami. Um, anyways, so we are training nurses um, by a six-fold increase of nurses. In terms of our um, doctors for the specialist areas. We have 18 specialist areas right now being done in country. So the residency program now covers 18 specialist area. The 18th was added this year, just a few weeks ago, in neurosurgery. But we have general surgery, we have orthopedics, obstetrics, gynae, pediatrics, emergency medicine, emergency trauma medicine, anesthesia, psychiatry, etc. We have training in these areas and taken between 5 and 8 new residents every year. In terms of allied health, we're not short of people for pharmacy and for medical technology. We have a rehabilitation bachelor's degree program at the University of Guyana for physiotherapy and speech therapy. Um, we, we, um, we have started programs for respiratory therapy, for training ultrasonography in ultrasonography. We're working with Mohawk University in Canada that will start working with us now. We're working with McMaster, um, with Harvard, with um, with Stanford, with Vanderbilt, Dalhousie, etc. To for specialist training of our doctors, and so when we started out, when I was Minister of Health, we graduated 30 between 25 and 30 doctors per year from the University of Guyana. As of this year, the incoming class is 77. We hope by next year the incoming class will be 100. Texila, which is accredited by CAM HP, which is a Caribbean accreditation board, and by the ACCM, which is a global accreditation, American and European accreditation of Texila University, is graduating about 20 Guyanese students in addition to other students. We continue sending students to Cuba, to India, to China for undergraduate studies in medicine. So I think that we are not just transforming the sector by building larger hospitals, more higher level hospitals, new hospitals. We understand that buildings and equipment do not deliver service. It is still human resource. And so it is hand in hand. One has to plan ahead for these things, and that's what we have done. Unfortunately, the 5 years we were out of government, the human resource plan that we had introduced when I was minister was derailed a little bit. But we are not, mourning and bemoaning that fact. We are just moving on and training people. So um, that's the human resource, the answer for the human resource question. We are putting in local training, but we are also working with our international partners um, to send our students for fellowships, etc. Right at this moment, there are 20 of our young doctors in different parts of the world, in Canada, in the US, in India, in China, that are doing fellowship. These are specialist doctors who go on to these universities so that they can learn new techniques, the most modern techniques, state of the art techniques, things that are just now developing and coming to Guyana to deliver that. And we have people presently at Northwell and at Mount Sinai doing fellowships in New York. We are about to send 4 people to Mount Sinai to be trained in pathology. Um, we are about to we are about to launch in November a modern pathology lab with Mount Sinai. This will have equipment that we procured at about close to 3 million US dollars, and fully automated pathology lab that will allow us to prepare all of our specimens right in Guyana. We don't have to send them anywhere, and will allow us to access the expertise of pathologists around the world, because they would be able to view the specimens and view slides, view tissues, and so remotely using the remote technology that we have introduced. And so the constraint, some of the constraint of not having people physically here are overcome by using technology. Um, and so we are very proud of that human resource development that is occurring right
All
now.
right. Thank you very much, Doc. Very elaborate and it's very encouraging to know that that's the path you're walking on. Now, Professor Budu, your question to Dr. Ramsamy.
Dr. Ramsamy, we have a piecemeal information on the transformation that is taking place in Guyana, including the health sector.
I know.
Right. I went, for example, at the Ministry of Health website to see if I can get a more general picture of what's going on there. No information. I went to DPI website, no information. Now, I've been messing around with AI for a little while, and just before coming on the program, I decided to ask ChatGPT, what are the requirements for a modern hospital? And then I change it and ask it, what are the key requirements for a modern hospital in a developing country? Then I specifically address it, what are the key requirements for a modern hospital in Guyana? And the intention there was to see whether the requirements are different. And truly, it brings up different requirements. So you can't expect the requirements in the US to be the same as Guyana. What I want to do is to read some of these requirements to you. And if you could briefly tell me what you are doing in these areas. So the first one is basic infrastructure and utilities. Ensure reliable electricity, clean water supply, proper sanitation, waste management, backup power supply system to maintain continuous hospital operation. What's your comment?
Okay. So the transformation that is occurring presently, and that started on the Barjak day when he was president, address all of those issues. Infrastructure, I don't want to spend too much time. I think the last time I spoke, and the reason that I am not in my office right now or at home joining this program, I had to stop on my way back to Georgetown in order to join this program, is that I was in Barbies. Um, we had just last week signed the contract for a New Amsterdam hospital at a cost of 161 million US dollars. And the design of that hospital take all the things that you just spoke about. Um, all of our hospitals presently, those where electricity is available, have backups, because we are still struggling with having a reliable electricity supply in Guyana. Hopefully, with the Myla, with gas to shore project, we will have more reliable electricity and less dependent on backups. But all of our hospitals where we have electricity from the grid, um, that includes Georgetown, it includes all the hospitals in Barbies, it includes Essequibo, Linden. All of these hospitals have backup systems, backup generators. Um, in the case of some of the hospitals, like at Cato, at Maruka, um, at Camarang, um, Paramakatoy, Latem, Mabaruma, Maruka, Matthews Ridge, all of these other hospitals that are offline, not on the grid, they are supported by generators with some supplementary electricity from solar panels that we have included in these hospitals. Um, so what we are doing right now during this transformation, building new hospitals to replace the old hospitals, is to ensure that they have continuous, reliable electricity, and whether that means adequate backup or not, we are making sure that those things are available. In terms of that infrastructure, we have to ensure that we don't build hospitals like we used to. So one of the important component of the infrastructure is IT. You talk about artificial intelligence, and we have to use now the internet connectivity is critical, so that we have to build in the connectivity and the IT infrastructure to support these things. Water is, of course, critical. Every hospital, every health center in Guyana today have access to water. In some cases, it's water from the national system, Georgetown, New Amsterdam, and so depend on Guyana water. Um, However, there are places where Guyana water doesn't have the system that we have on the coast. And we have to support that with its own wells, providing water treatment, etc. The hospitals that are being built now have modern treatment plants. Um, it, and in some cases, it's not just treating all the water that comes into the hospital, but we have to have specialized water. You can't have a dialysis center, even though the water might be treated that comes from the national system. We have to have specialized, sterilized water that comes into the system. So the hospitals are built with these systems right now. That was missing before. Those are now in place. So yes, we are doing that. One thing that you didn't mention that AI would have put in is paper-based system um, cannot support a modern hospital. We have to replace our paper-based system with electronic systems, electronic medical record, electronic health.
Actually, I'm coming to that. I'm coming to that because that's another one on the list. I just
Yeah.
wanted to get some brief answers from you because it's a big list and I don't want to go through all of them, but I know medical record is one of those. The second one on that list is primary and preventive care. It says emphasize primary healthcare services, including vaccination, maternal and child care, health nutrition program. Your comment, brief comment.
Okay. Um, so when I became Minister of Health, virtually everything we did was primary and secondary care. We had very little tertiary health care in this country. We have transformed that. Guyana's strength in this region has always been our primary health care. So presently, we have 382 health centers and health posts in the country. There is not a single community today that don't have access to a health center or a health post in Guyana. This is purely primary health care. In terms of vaccination, and virtually all vaccination, excepting the specialized ones like yellow fever that people need for traveling, etc., that adults need, but all children vaccine. And we provide 18 different antigens for our children, one of the widest spectrum of vaccination in the world. And for all of those, we are between 95 to 100% coverage. When the US gets 75%, it's a great coverage. For us, it's 95 to 100% coverage. Um, and the only persons that have any kind of vaccine preventable diseases when it comes to children right now are newborns just within their first week, because we have a lot of their family traveling from the diaspora who are not vaccinated and who bring things, and the baby is not yet protected. One such, and I will encourage people from the diaspora, if your relative is having a newborn baby, you can come, don't go visit the baby. Wait. Because unless you are vaccinated, don't come see them. And one of the things that you bring here is whooping cough. Um, and so we have a very strong primary health care system in terms of maternal child health, antenatal care, etc. However, in recent times, we're strengthening that. And we are adding the chronic diseases, etc. So from Enmore, it's not everywhere yet. From Enmore, soon at Lusignan, I was just at Port Morant. We're going to introduce it at Port Morant Health Center. We're going to add retinopathy screening. This is where Dr. Sugrim in Georgetown, the ophthalmologist at Georgetown Public Hospital, and his team will be able to screen people from remote areas. So we're putting in those systems right now so that people can obtain such care at the local level. We we have something called VIA, which is visual inspection with acetic acid, which is able to have detection of cervical cancer at the primary healthcare level. We are adding screening for hearing, for vision, etc. We're going into the schools. We're taking screening into the schools. And amplifying an exercise that the colonial had in our country. All of you are old enough probably to remember the dental buses coming to the schools during the colonial days. That's when people like my generation used to have belly aches, and so we can't go to school because we were fearful of the dental bus. So we are reintroducing the dental buses. We are screening every child this year. We've begun every child in school will be screened for vision, and those who have impaired vision will be provided, if it's a matter of refractive index problem, they will be provided with glasses. If it's a matter of some pathology, they will be taken to the hospital and treated. So we have a very strong primary health care. Doesn't mean it doesn't need strengthening. And so, you know, for those of you who are diabetic, you know, we have to have HbA1c. Now that is being introduced into the primary healthcare system in the um, health centers. So 55 health centers out of the 382 as of today are able to do HbA1c for the people who live in their catchment areas. So I can go on, but I think you get the gist. There is a strong primary healthcare service in Ghana that we are strengthening right now.
Yeah.
Okay,
All right. Let me ask you one more, and then I'll pass it on to Professor Prasad. The other one on the list, the emergency services. Develop a well-equipped emergency department capable of handling trauma cases, accidents, and critical care, especially considering Guyana geography and potential transportation challenges.
Yes or no? So Georgetown Hospital, because we now have a postgraduate um, training program in trauma and emergency, um, and all the shifts have trained trauma doctors, trauma nurses in the ER. We need more. We need to double the staff at GPHC so people could move quickly. Um, we have trauma doctors now at New Amsterdam ER and at West Demerara Emergency Room. But we need to train more so that all of the centers could have trauma specialists working. And that's why I mean yes and no. I think in the case of our postgraduate training, we work with Northwell, Mount Sinai, and Vanderbilt. Vanderbilt is the lead um, partner in the postgraduate. They do a lot of the examination, etc. Um, but a lot of the experience and so is developed working with Northwell and Mount Sinai. One of the trauma cases that we had no capacity for up to say 2006 was burns. We had nobody to deal with burns in this country. We introduced that program. A burn center was established in 2006. That has grown, and we now have specialists to deal with burns. We don't have all of the services yet, and that is why one of the many patients out of the Madia tragedy had to be sent to New York, to Staten Island, at the Northwell facility burn center in Staten Island. So it's a work in progress. We should all be proud of the work the young doctors are doing at Georgetown Hospital and New Amsterdam Hospital, to a lesser extent at West Demerara Hospital. But they are being overwhelmed. We need many more, especially since road traffic accidents have become, um, uh, it's increasing every day. Um, and violence and so on have contributed to some of the trauma that we face. In terms of the other kinds of emergency, such as heart attacks, people having various cardiac problems, um, kidney failure, and so on. We're dealing with that because, in addition to the ER that could provide care, there are specialists now for cardiac care. We do on a monthly basis about 250 to 300 interventions for cardiac emergency. These are things like stents, angioplasty, etc. Guyanese doctors. This is not Dr. Gary Stevens, because they come in once a month and they do about 12 to 15 open heart surgeries. But in terms of stents, angiograms, angioplasty, and so that would show up in the emergency room, Dr. Carpen, Dr. Chin, Dr. Haynes, Dr. Court, they all are able to respond. In terms of renal failure, Dr. Kishore and, 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 and Dr. Martin, in terms of vascular surgery, they are able to deal with these things. Orthopedics, neurosurgery, such as brain injuries, and so we have the capacity to deal with them. If we have a huge accident, say 20, 30 people at one time with multiple injuries, including brain injuries, and so it might overwhelm us because we don't have enough surgeons that could take multiple people at the same time. But it's a work in progress, and we are getting there.
All right. Thank you very much, Doc. Let's move on to Professor Narayan. Your question for Dr. Ramsamny or clarification.
Dr. Ramsamny, you said that at one time or the other that you believe in a paradigm shift in medicine, and that there should be, within your paradigm shift, a convergence between the pragmatic and the practical. Would you like to elaborate on that?
Yes. One, we would like to have everything the US have today. We don't have everything that the US have today. We will one day soon. And I think that all of us in this chat, hopefully, will still be around when we see that happening. But we have to be practical. One, health is very costly. We are not going to be able to have an MRI in every hospital in our country. I don't think every hospital in the US has an MRI. That's why they refer people to diagnostic centers. And that creates a problem, right? Because people who live in the hinterland and so, for equity reasons, so would want to live near where these services are provided. We're not going to be able in the short term. But when I said those words, when I was Minister of Health, I didn't envisage that the public sector would have an MRI in my lifetime. And so we encourage the private sector to bring in, and we procure on behalf of our patients. I can say to all of you, and you should write it down and hold me to it, and hold our government to it, that by the end of 2024, well, let's say middle of 2025, the public sector will have one MRI, And by the end of 2026, we will have three. We can provide everyone with a transplant. But when we started transplant back in 2007, people thought we were going to kill people. We have one of the most successful transplant program in the Caribbean right now. We are about to do our first pediatric transplant, kidney transplant, in 2 months' time. And we are about, because of the work with Mount Sinai and the pathology lab, we'll be able to do our first cadaver transplant before the end of the year. We have already completed 250 corneal transplant, and we will begin establishing a eye bank. Last night I was talking to the experts so that we could begin a bone marrow bank in Guyana. Um, so this is the paradigm shift, and the paradigm shift is whilst our focus was on building a strong primary health care program, and that tertiary healthcare, we will have to rely on either outreach program coming to the country or sending people abroad. The paradigm shift is that we must have the strongest primary healthcare that is possible, but at the same time also having tertiary care at the highest level, at the highest quality, right here in Guyana. And that is why the New Amsterdam Hospital will also have a cath lab. So people could have stents and open heart surgery. We will extend the transplant center to places like that. But that don't leave the hinterland out. As we speak right now, a team is linking three remote areas, um, Carisparu, Arau, and Chinapal, to Georgetown Hospital using telemedicine. So that some of the things that we would have thought impossible in the past, we are creating that paradigm shift that nothing is impossible now with the use of technology. Right now, I could tell you that our infant mortality rate is one less because a child in the furthest, remotest village of Guyana was able to be saved by a doctor who was physically in Georgetown. That a 64-year-old man who had sepsis because as a result of a kidney stone, and who would have had to walk 5 days to the hospital, is alive today because we were able to intervene from Georgetown, medivac him after the diagnosis was made here. We are bringing health to the people. We are bringing hospitals to the people. And that's a paradigm shift that I was talking about. That whereas our generation at one time thought that these were impossible dreams, we are making it happen right here in Guyana. And whereas it was, I think you guys remember names like Dr. Sharple, and other names, foreigners who came to Guyana. It is our children, cane cutter, fishermen, farmers, rice farmers' children. Right now, Dr. Narayan, I heard you are from Bath. Well, you know what? When rice production doubled between 2012 and 2015, and 2014, it was a seed scientist from Bath Settlement that made it possible. And the same thing is happening with our doctors now. The team of Carpentian and Haynes, as a single team, has done more cardiac intervention than any other team in CARICOM. When I became Minister of Health, we had to consider our Caribbean colleagues as way, way ahead of us You know what we're talking about right now? That by 2030, Guyana is taking the leadership in healthcare in the Caribbean. And the direction where we went to the Caribbean is going to move this way to Guyana. That's the paradigm shift. Nothing is impossible for us right now.
Professor Narayan, any
That
follow-up?
sounds a little bit
Yes.
arrogant.
Yeah. I just have a follow up. Before I go to the next question, I have this one follow up as a clarification. Within your paradigm shift, I am supposing that preventive health is a component of that.
Any health strategy or any health investment that don't make preventive health the priority is one that will fail. Preventive health has always been what our priority is, um, and that involves research and taking health to the people. Good nutrition. Incidentally, this week is Global Breastfeeding Week. Um, Vaccination, immunization, exclusive breastfeeding for the baby, all of these things are important preventive care. Dealing with dengue, for example, and first of all, addressing the reservoir, which are human beings carrying the parasite, and the vector, mosquito. These are important preventive measures. Identifying hotspots for malaria and going in and dealing with the vector, making sure people get treatment so that there is no parasite to be transmitted, are all things that we have to focus on. The screening program for vision, for hearing, etc. The screening program for cervical cancer. We now know that HPV is a contributor to cervical cancer. We know hepatitis C is a contributor to liver cancer. We know that H. pylori create major different kinds of abdominal illnesses. And so screening people, as they could live 10, 15, 20, 30 years with these things. And then the consequences come up later that become problems for hospital. So these screening programs are being activated and kept every day. The eye screening program, introducing HbA1c in the health centers for maternal, for antenatal clinics, etc. These are all part of the preventive medicine program. We now have about 1,000 young people paid by the government, the part-time workers that are linked to health, that are going in with scales, with measurement, with measuring tapes, doing people's BMI. We want every Guyanese to know their BMI, so they begin to eat well, to exercise, etc. We are addressing the issues of smoking. We have introduced a gatekeepers program in the villages so that we could address the issue of domestic violence, of other psychosocial issues that we have. We're working with McMaster and York and Mount Sinai to develop an addiction prevention program and an addiction treatment program. So it is a very, very ambitious. Is it all going to work out fantastic from day one, from today? Do we have all these programs that are very strong? The answer is no. We need to put in counselors in the schools, all of these things that we have ambitiously put forth, but we'll have to train more people and roll these out more. So prevention is at the epicenter of the health strategy in Guyana.
Okay, thank you.
And
Professor Narayan, you have a quick follow-up?
yeah, I have a quick question. In terms of your pragmatic and your practical, is there some component of indigenous medicine in that? What do I mean?
Yeah, go ahead.
You know, when I was growing up, you talk about youth and growing up. When we have a sprain, we go to the guy who in the village knows more about that. We also know that in the past, that housewives, um, we have that many of the deliveries were done by midwives in the village. And there is a certain amount of indigenous knowledge that is there in terms of the pragmatic and the practical. Do you see an integration of that in the delivery of medicine within Guyana?
Absolutely. And that is why when I was minister, we passed the Allied Health Act and enacted the Allied Health Act because we recognize that there is that indigenous component to health, but there's a growing knowledge also of Ayurvedic medicine, etc. India is the lead country
Yes.
on those traditional medicine. Um, I suspect, I don't know for sure, that I was delivered by one of those midwives. I am alive today. When I became Minister of Health, because of the influence of PAHO and WHO, where they wanted to ensure that all babies are delivered in hospitals and that there are doctors and midwives, trained midwives, and therefore if I use the youthful term of dissing the those midwives you talk about, but in the hinterland community they call them the nannies, and culturally those people prefer the nannies. Um, and so my thing to our health workers was these are people who are doing it and will continue to do it no matter what we say. When a lady in Saint Ignatius or Anai or Napi is about to deliver and the hospital is far away, what will they do? The nanny comes over. And so why not bring them into the fold? Let's train them to do what they do anyways, safely, better and safely with a higher quality. And so we brought them in and we trained them. Um, but today we recognize at that time nobody talked about um, acupuncture, for example. We have integrated all of these in our healthcare system, and I'm glad to say that six of our young doctors will be traveling to India, the Ministry of Ayush, which is the Ayurvedic medicine ministry. They have a special ministry in the Indian government for this. Have made arrangement with us to train our people to come develop research here. We're doing all of that right now. So but these things, whilst we integrate them formally, we have to ensure that we have the proper laws, and so that you don't have people just putting up their nameplate and doing things. The indigenous knowledge, traditional medicine have a history, and there are positive aspects to it, but there are also the negative aspects to it. We have to harness the positive ones and make sure that if we formalize those practice, that it's done in accordance with quality, standards, safety. Those laws and so, and how we accredit people, etc. We are learning from India. We hope to have a very strong component and lead this region in terms of traditional medicine.
Okay, we actually almost program time, but I just got a text from one of the viewers, And they said last night at the West Delaware Hospital, a patient went and there was no oxygen. And the family had no alternative but to rush to Georgetown. And so, how I know that wasn't you're in charge of the Georgetown Public Hospital, you're the chairman, but as advisor to the minister, how would you deal with a situation like that?
We we hear such complaints now and then, and I definitely, as soon as I get home this evening, I will make a call to West Demerara to find out why they wouldn't have any oxygen. And it's not impossible. I find it a little bit troubling that such a report comes out. But for I think for all of you, you must have been in a hospital in Ghana. You know that prior to when I became minister, that oxygen in our hospital was cylinder oxygen. They roll the cylinder from ward to ward, and that's how you got your oxygen. There was no wall oxygen therapy like a US hospital where they just pull from the wall and you get oxygen. We introduced that at Georgetown Public Hospital, and the new COVID infectious hospital has that also. We've started it in New Amsterdam and Linden. We're starting in Latem, West Demerara. We didn't start. They're still relying on cylinders for oxygen, and I'm suspecting that they ran out not from the hospital, but in that specific clinic, and difficulty getting a cylinder there. I'm not saying that that's the case. I have to check. But that's the new shift that we are doing right now, that no hospital will be utilizing cylinder oxygen. All of them will have oxygen generating plants on site, like Georgetown Public Hospital, like Latham, like Linden. Um, and so that's the new direction we are going right now. Um, so I will check that out, and
I appreciate if we can do that, Doc. Our time is up. Let me just pass you. It's a very interesting conversation. I'm sure all of us learned so much plus our views. But I pass you over to our host, Shamisa.
Thank you, Dr. Tara, and thank you to our panel for tonight's discussion. Dr. Ramsamny, we will now ask you for your closing remarks.
I first of all, let me thank all of you, Guyana Dialogue, for continuing to focus on various aspects of Guyana's development, but more particularly because I am at the Ministry of Health, the focus on health. I have been on several times. I know Minister Anthony has been on. Um, and we are kind of the poster child for development in Guyana. Um, by 2025, the government of Guyana would have invested 1 billion US dollars in the health sector, physical transformation, um, and we will continue to do that. When the next project, and now that we have finished putting New Amsterdam on paper, when Georgetown Public Hospital redevelopment is completed, hopefully sometime by half of next year, this is the plan, the design and plan, and the investment made in that. It will likely be the largest ever health project in the whole of the Caribbean. For those of you who know Trinidad, Mount Hope, this is going to be a bigger project. It is because we believe that health is the wealth of the nation. And we believe that we have to ensure that our health system become one of the best in the Caribbean. But we are also targeting you. We want you to come home. We know a lot of people reaching retirement age would like to come back and settle in Guyana, but they are still worried about their health. We're not, crazy and not recognizing that. We are cognizant of that. And in order to attract them back home, we have to create a healthcare system that is going to create some confidence and bring them. And I want to assure all of you that it has started already. It will take some time, but I believe by 2026, 2025, 26, Guyana will have a health system comparable to any in the Caribbean. And that we will begin to create some confidence in the diaspora that they can come home and they can live at home and they can enjoy the same high quality health care they have in the US. Professor, that's a paradigm shift. Our ambition knows no limit.
Yeah.
And we think we can do this. We must do this. So we're looking forward to one day talking again, in 2025 and say, hey, come home. We have the healthcare system to take care of you. But as you know, many Americans and Europeans go to India for healthcare. Medical tourism is a big thing in America, in India. One day, oil will leave us. Agriculture, health services, etc., will be our economic income. So we are looking at health for people to live long, disability-free lives, for our people who live abroad to come home, but we are looking to generate revenues for our country. That is the PPP's plan for healthcare. That is President Irfan Ali's main focus, the epicenter for the development of our country, health and education. And what a proud time for you, for me, for all of us, that healthcare in Guyana is being delivered by our sons and daughters, people from the villages all across Guyana. There isn't a single village in this country anymore that has not produced a doctor. Man, we should be proud.
Thank you very
And
much.
so we are. We are very proud. Thank you so much, Dr. Leslie Ramsamny, to our entire panel, and to our viewers. Thank you for taking the time to be here this evening. Until next time, this is the Guyana Dialogue, and I'm your hostess, Shamisa Ali. Good evening, everyone.
Good
Thank
evening.
you. Thank you,
Thank
everyone.
you. Thank you.